morning, Doctor. So today our presentation for today is about transcranial magnetic stimulation (TMS) for treatment-resistant depression, and our team member are me, myself, Erina, Sima, and also Anis. So let's go for the introduction. So TMS is a technique that uses a changing magnetic fields that used to stimulate the brain's outer layer by bypassing the resistance of the skull and surrounding tissues. So TMS was first introduced in the middle of 1980s and has gained popularity as a research tool in neuroscience and as a treatment for various neurological and psychiatric disorder. So TMS is actually non-invasive, which means that it does not require any surgery or implantation of electrodes. So it's typically using a handheld device placed on the scalp, as a picture shown, and the sessions are conducted in an outpatient setting. So TMS is actually considered as safe and well tolerated with a minimal risk of serious adverse effects. And despite doubts about its effectiveness, TMS has proven to be valuable in addressing the treatment-resistant depression. So TMS will utilize the electrical energy to produce the magnetic effects, enabling the control of neuronal excitability with pulses of either high or low frequency, 10 to 20 or 1. TMS provides the benefits compared to ECT, such as targeted stimulation and not needing anesthesia, which make it a suitable choices for specific situation. So next slide is types of transcranial magnetic stimulation (TMS). So we have three types: for single pulses, paired pulses, and repetitive TMS (RTMs). So for single pulses, single pulses is actually in single pulses, transcranial magnetic stimulation is a pulse that administered at intervals of at least a few seconds. For paired pulses, it involves in applying two pulses simultaneously to either inhibit or excite the neurons in the same hemisphere, or to inhibit neurons in one hemisphere while exciting those in the other. So for the last one, repetitive TMS, RTMS. So during the RTMS, magnetic pulses are given in a quick session, known as a train. RTMS involve delivering several individual pulses of stimuli at a specific frequency, intensity, and duration. So, which means it allows for either existing or inhibiting activity in the impacted part of the cortex. A demonstration of slow repetitive transcranial stimulation will be performed at a frequency of 1 Hz, indicates that one magnetic pulse is administered every second, or also called as 1 cycle per second. And a fast repetitive transcranial magnetic stimulation at a frequency of 10 Hz involves delivering 10 magnetic pulses per second, 10 stimuli per second.
Hi, my name is Nur Anis Najah binti Ramli, and I will explain on the mechanism of transcranial magnetic stimulation. So the first mechanism involves a generation of magnetic fields, which the transcranial magnetic stimulation use a coil which is placed on the scalp to generate rapidly changing magnetic fields. So this field will pass through the scalp and skull without a significant attenuation. And the next mechanism is electromagnetic induction. So when the magnetic field changes within a closed loop, which is the neural tissues, it will induce an electric current. So this induced current can depolarize or hyperpolarize neurons depending on various factors. Next is neural activation. So the induced electric current can lead to the firing of action potentials in neuron. So this neural activation is basically a basis of TMS effects on the brain function. Next is selective targeting. So TMS will allow for selective targeting of specific brain regions. So by adjusting the position and also the orientation of the call, practitioners can focus on the magnetic fields on particular cortical areas. The next one is pulse parameters. So transcranial magnetic stimulation can deliver a single pulse or repetitive pulse at the different frequencies. So high frequency stimulation can increase the cortical excitability, and a low frequency stimulation will decrease the cortical excitability. The next one is neural network effects. So TMS can modulate neural activity not only in the directly stimulated area, but it also in the connected brain regions. And the last one is plasticity and long-term impacts. So repeated sessions of TMS can induce neuroplastic changes in the brain, which can lead to a longer lasting effects. And this can involve changes in a synaptic strength, neural connectivity, or neurochemical modulation, which can contribute to its therapeutic potential for various factors. So the next one is a neurotransmitter that involved in a transcranial magnetic stimulation. So the first neurotransmitter is serotonin. So the improvements in the speech and movement, facial expression, and also voice volume are linked to the both clinical benefits and antidepressant effects of repetitive transcranial magnetic stimulation, which is a type of TMS. So these effects are believed to relate to changes in neurotransmitter systems, particularly serotonin 5-HT, which plays a role in a regulating mood. And the people with depression often have lower levels of 5-HT activity in certain brain regions. So the activation of the DLPFC may affect the serotonin receptors in the hippocampus, which is another brain area involved in the mood regulation. And the patients who undergo this chronic RTMS show a decreased sensitivity of serotonin autoreceptors, which can regulate serotonin levels in the frontal brain. So the next neurotransmitter is dopamine. So the changes in the expression of peripheral receptors and transporters in the dopaminergic system may serve as biomarkers for the diagnosis. So the prefrontal RTMS has been shown in both human and animal studies to elicit the dopamine release in the mesostriatal, mesolimbic, and striatal areas, which can contribute to its antidepressant effects. And the acute RTMS challenge exhibited striatal dopaminergic effects, which resembling those brought on by D-amphetamine injection, which is a drug known to elevate the dopamine levels in synapse. And the last neurotransmitter is gamma aminobutyric acid. So the decreased levels of brain-derived neurotrophic factor and diminished indicators of GABA function have been linked to the MDD. And the reduced GABA-mediated suppression of the incoming of information in the pyramidal dendrites may be a potential microcircuitry level trait that can underlie the often observed enhanced activation of the amygdala and subgenual anterior cingulate cortex, which is the SACC, in the MDD patient. And the distinct repetitive muscle stimulations may have an impact on the expression of activity-dependent proteins in the cortical inhibitory interneurons, including a glutamic acid decarboxylase, which is GAD 65 and 67, the GABA transporter 1, and also intermittent and LF stimulation.
Thank you, Anis. So now we will proceed on the main part of our presentation, which is the critical appraisal of the articles. So in our report, we have included three main articles, which is the first articles involves EEG synchronized left prefrontal TMS for treatment-resistant depression patient, which is a randomized controlled double-blind clinical trial. This study involves more of a inclusion of EEG, which is synchronized. TMS is the pulse of TMS is synchronized with the EEG, which is the brain impulses. So the next article is on the advances in TMS and its application in resistant depression, which is a review article. And the last one is the left prefrontal TMS for treatment-resistant depression in adolescents, which is also a double-blind sham controlled trial. So I will pass it to Arina now for the first point of our critical appraisal. Thank you.
So let's proceed with 3.1 potential sources of bias. So in the realm of TMS, as with the clinical intervention, the potential for bias are carefully considered. Several sources of bias can be made in research. So most of the studies of TMS, the potential source of bias is selection bias. And to mitigate this concern, researchers employ various methodological approaches and rigorous study design, where it means like the researchers will be very clear with the informations which is the outcomes of the experiment itself. So current research uses the small scale study, or known as proof of principle study concept, which mainly focuses on the small sets of group or small sets of subject. So other than that, they use randomized control trials, RCTs, which are often regarded as the gold standard for evaluating the efficacy of interventions while minimizing the bias. So through the randomization, there will be allocation, concealment, blinding of the participants and the outcome assessors, and also intention to treat analysis. So researchers will strive to minimize the influence of biases on the study outcomes. Moreover, there will be a systematic reviews and meta-analysis which play a crucial role in synthesizing evidence from multiple studies, providing a comprehensive assessment of treatment's effects while accounting for the potential biases across the studies. Transparency in reporting, adherence to standardized protocols, and pre-registration of study protocols will further enhance the credibility and robustness of findings in TMS research. So continuous vigilance and methodological refinement will remain imperative to address the evolving challenges and ensure the integrity and reliability of research outcomes in field of TMS.
Thank you, Arina. So moving on for the second point of our appraisal, critical appraisal, which is it's the benefits of TMS compared to other approaches like a pharmacological approach and also similar other types of brain stimulation other than TMS. So for the first one, it's the synchronized TMS pulses with an individual's prefrontal alpha rhythms have shown more of an individualization of the treatment approach where every TMS pulses input on the patient were synchronized depending on the patient's brain impulses. So I mean brain rhythm. So it also showed an enhanced in treatment efficacy. So overall, it has increased specificity compared to pharmacological approaches. And the next one is they have less side effects. For example, repetitive TMS does not require anesthesia, as in like other treatment like ECT needs anesthesia. ECT is also a type of brain stimulation, and it has a very high efficacy, but then they have a very wide range of side effects also, like memory loss and cognitive loss of cognitive ability and all. So when compared to TMS does not require anesthesia, and also some studies show that patient with treated with TMS actually had better cognitive function and also memory. So that's the second point. And the third one is on the third study for adolescent. So generally, ECT has a lot of side effects, as I said before. So it is not really recommended for adolescent. But then since TMS is more safer, it has a higher percentage of good results. So it also show that most of adolescent who are treatment resistant depression who has treatment resistant depression do not really respond to pharmacological approaches. So TMS has a good alternative for this kind of conditions. That is one point. And then moving on to the comorbidities with faced by the patients. So most of the articles that we discussed or picked for this report does not extensively discuss on specific comorbidities experienced by the patient. But there are several other studies that have showed on the common comorbidities with TID, like alcohol use disorder, anxiety, and then other physical health issues like kidney disease, COPD, and heart failure. For alcohol use disorder, it's mostly like it is accompanied with depression, where people who are experiencing depression tend to like relieve their depression into alcohol, so they tend to become alcoholic. So the chronic alcohol use can actually affect the plasticity and alter the brain function. In return, when they are treated with TMS, it tend to interfere with the result. So more studies were done, and deep TMS showed a consistent benefits in reducing AUD and also depression, even though like they do interfere with them, but the different change of protocols like deep TMS have shown benefit outcomes. So in overall, addressing AUD alongside with PRD treatment-resistant depression is essential for optimizing treatment outcomes with TMS. So other comorbidities, like I mentioned, are anxiety, which are usually accompanied by depression. But then anxiety showed an increase in the severity of depressive symptom. As we know, TMS are actually designed to treat depression disorders, depression impulses, the brain regions that are responsible for depressive symptoms. But then anxiety are considered more severe than depressive symptoms. So when the patient is present with both depression and anxiety, the treatment of TMS should be reconsidered, and a different adjustment should be done. Similar to kidney disease, COPD, and heart failure. For example, like heart failure or COPD, the patient tend to have a weak blood flow and less lack of oxygen in to the brain itself. So when TMS therapy is provided, the response might be not as effective as it should be for other patients compared to patients with this condition. So to overcome all the situations, some adjustment in the TMS protocol should be done. As I say, TMS are more of an individualized uh, treatment style, so they can adjust the treatment protocol with how to say, like the change in duration of the sessions, and also how many hertz are given. Okay, so that is on this point.
So next, I will continue on the limitations of transcranial magnetic stimulation. So first, it is optimizing stimulus coil placements and also choosing suitable control stimulation. The second one is the limitation of variability within the study population, such as the mental illness, medication, heterogeneity in the given drug. The third one is the calculation of the length of a time that a patient will respond to the MDD. Next is the use of more structured clinical skills to improve the accuracy of the result. And the last one is the use of identical outcome definitions for study result and also psychometric scale interpretation. Next is future research of transcranial magnetic stimulation. So first is investigating the underlying neurobiological mechanism of TMS, such as their effects on the neural circuits and neuroplasticity, which can provide the insight into its therapeutic effects. The next one is exploring combination therapies involving TMS with other interventions like pharmacotherapy or neuromodulation techniques, and also improve treatment outcomes. The next one is further research. Doing further research is needed to better identify and also localize the target brain regions for transcranial magnetic stimulation treatment, and also to understand the factors that contribute to the treatment resistance and also predictors of response. And the last one is a long-term studies, which are essential to assess the durability of the MS effects and also to optimize the maintenance strategies, which is to prevent the symptom relapse.
Okay. So for the last point on our critic appraisal, which is clinical impacts of TMS. So here I will explain the overall insights of the three articles that we have done and what are the clinical impact of it. So in the first article, which is where they did the synchronization of TMS with EEG, actually showed no difference with unsynchronized TMS, even though they had a good result from performing the synchronized TMS. When they compare with unsynchronized TMS, there was not much of a significant difference between both the outcomes. So in that case, maybe further studies to adjust the protocol or the duration should be done on this synchronization of EEG and TMS, because theoretically there have been a lot of evidence showing that there are higher higher impact of the TMS response to the brain when it is synchronized with the brain rhythm. But then when the study is done, the result is a little unexpected. So the clinical impact is a little less on this study because they need to do more clinical trials to actually validate this method and protocol to be bring it on the real life treatment situations. So to the second article would be on the review. It highlights on a lot of factors that are needed on the clinical impact of TMS. So mainly patient characteristics are involved, such as age, duration of current depressive episode, and also the presence of psychotic depression, which can impact the response rates. Moving on to the last article, showed also a lack of significant difference in efficacy outcome, which is compared to the adolescent group and also the sham group. So there's also further research that is needed to be done to better understand its effectiveness. Nevertheless, even though when they compare with the placebo group or the unsynchronized group of TMS, they showed no significant difference, but the actual outcome, the overall outcome has been very good with a very minimal side effects, only like a very light headache and dizziness was the common side effects noted on these clinical trials. So from my conclusion, it would be that TMS is still a very promising approach for to treating TRD, treatment resistant depression, but they need further studies to have a strong evidence to show that it can be like for different protocols in different situation of patients, like how the comorbidities I've explained earlier. So that is all from me. Thank you.
So, for the conclusion, to sum up everything that has been stated, TMS works by using a fast-changing magnetic fields to generate electrical currents in particular areas of the brain's outer layer, which called as a cortex. So through this bypassing the resistance of the skull and surrounding tissues, TMS may alter the neuronal activity and connectivity, which in turn impacts the brain function and behavior. This non-invasive method has shown effectiveness in different neuropsychiatric disorder, especially treatment-resistant depression, through providing specific stimulation without requiring any anesthesia. So despite its potential, current research efforts are focused on improving the TMS protocols, perfecting the treatment parameters, and understanding how it works to improve the therapeutic results. Nevertheless, numerous criticism and obstacles continue to exist in the field, requiring to focus and continuous research. So a true examination okay, the first criticism is a long-term effects and safety. So a true examination is needed to assess the long-term impact of the MS treatment and its safety, particularly in relation to possible side effects and how long therapeutic benefits last, since most of the study takes about 2 to 3 years to finish up this TMS experiment and study. Monitoring and evaluating treatment outcomes is crucial to guarantee the safety and well-being of patients receiving TMS therapy. So next is comparative effectiveness. There are only a few comparative studies that assess how effective the TMS is compared to other treatment options like medication or psychotherapy. Additional studies are crucial for informing the clinical practice and treatment guidelines by comparing TMS with standard treatments and investigate the role in combination therapies. And the last one is access and cost effective. So although the TMS therapy may have advantage, factors like access to the specialized equipment, trained staff, and financial limitation may restrict its availability. Evaluating the cost effective to TMS compared to other treatment choices is essential to guarantee the fair access and long-lasting usage in clinical environments. So for the benefits and future prospect, first for the minimal side effects, TMS will continue to develop and broaden its use. The core idea remains centered on using the electromagnetic energy to influence neural pathway, opening up and new possibilities for comprehending and addressing the brain illness. So TMS may offers many advantage and bright prospect in neuroscience and therapy, including the ability to be used on its own or alongside of other treatments like medication or psychotherapy. So its ability to be used as a complementary treatment provides healthcare providers with opportunity to customize the treatment plans according to each patient's specific requirements. So TMS has a fewer systematic side effects and does not need anesthesia in contrast to pharmacological intervention or ECT. So this factor will makes it an attractive choice for patients who may not do well with or react positively to standard therapies. So other than that, progress in neuroimaging and neuropsychological methods allows researchers to gain a deeper comprehension of variance in brain structure and performance among individuals by utilizing specific neurobiological markers like functional connectivity patterns or neuroplasticity profiles, TMS. Treatments can be tailored to each patient for better outcomes. And that's all from us. Thank you.